Thank you so much. Moving forward to our next session, that is Hilar Cholangiocarcinoma. I would request the chairpersons, Dr. Saikat Gupta, Dr. Sumit Gulati, Dr. Jayanta Chakraborty, and Dr. Mallika Tiwari. I would request you all to please join the chair.
Good afternoon, everybody. We will start the session now. And the first talk is by Dr. Yoshihiro Sakamoto. And he will be speaking on Hilar Cholangiocarcinoma versus GB neck, the Japanese approach.
Okay, nice to see you. Good afternoon, everybody. I'm Yoshihiro Sakamoto from Kyorin University Hospital in Tokyo, Japan. I will start my lecture using the video. Please start it.
Hello, everybody. I am Sakamoto from Kyorin University Hospital in Tokyo, Japan. Today, my talk is about the Japanese experience of optimal surgical treatment for hilar bile duct cancer and gallbladder neck cancer. I have no COIs. Patients with hilar bile duct cancer and gallbladder neck cancer sometimes present similar clinical symptoms and imaging manifestations and require same surgical strategies. However, preoperative diagnosis of gallbladder cancer is more difficult than that of bile duct cancer. The 5-year survival rate of patients with bile duct cancer who underwent curative surgery is about 30 to 40%. However, that of patients with gallbladder cancer involving the hepatic hilum is only 10%. The first topic is about preoperative diagnosis. Many imaging modalities are used for preoperative diagnosis of these cancers. In the diagnosis of hilar bile duct cancer, MDCT before biliary drainage, endoscopic cholangiography, and mapping biopsy will be very useful to predict cancer spread. On the other hand, in gallbladder cancer, several imaging modalities are actually useful, but they cannot differentiate cancers from benign diseases absolutely. Percutaneous biopsy is not accepted in Japan because it may cause intra-abdominal dissemination. I will show a sample of preoperative imaging studies and mapping biopsy for hilar bile duct tumor. The patient had a bile duct tumor involving the right hepatic artery. The right and left ductal walls were thickened on the MDCT before biliary drainage. Endoscopic cholangiography showed the stenosis of the perihilar bile duct and IDUS. Intraductal ultrasonography revealed the thickened wall of the right bile duct. Mapping biopsy was positive for the main lesion, but was negative for right and left bile ducts. This patient underwent extended right hemihepatectomy and resection of the extrahepatic bile duct. The surgical margin was negative for cancer. Next is a sample of imaging studies for a gallbladder tumor. The dynamic ultrasonography revealed the thickened gallbladder wall and intratumor arterial blood flow. Dynamic CT scan showed enhanced gallbladder wall, and the MRI suspected gallbladder cancer. However, the surgical specimen showed xanthogranulomatous lesion, a benign disease. It is very difficult or almost impossible to differentiate benign disease from cancer. We previously reported that the diagnostic accuracy of preoperative imaging for gallbladder cancer is only 53%. The next topic is about the optimal surgical procedures for each cancer. Firstly, the optimal surgical procedure for hilar bile duct cancer. Bile duct cancer sometimes has 4 types of cancer spread. It involves the ductal wall vertically, and it extends along the mucosal and submucosal layers horizontally, and it shows lymphatic metastasis or hematogenous distant metastasis. Thus, to achieve curative resection of bile duct cancer, extensive hepatectomy, extrahepatic bile duct resection, and nodal dissection are required. Right hemihepatectomy with collateral resection, nodal dissection, and extrahepatic bile duct resection is the standard procedure for Hilar bile duct cancer. In patients with widespread Hilar bile duct cancer, right hemihepatectomy plus pancreatic duodenectomy is sometimes indicated. However, this surgical procedure carries high surgical mortality rate, up to 10% even in Japan. Thus, should be performed in highly skilled centers. After precise preoperative diagnosis, when extended right hemihepatectomy is required, CT volumetry to measure the future liver remnant volume and ICZ-R15 test to evaluate the hepatic function are the next important examinations. Then we judge the necessity of preoperative portal vein embolization. Preoperative portal vein embolization was firstly performed by Professor Makuchi in 1984 to increase the future liver remnant volume before extensive hepatectomy. 3 weeks after PV, the future liver remnant volume will be increased by 10% of total liver volume. This dramatically decreased the incidence of post-hepatectomy hepatic failure. Thus, the reported surgical mortality for Hilar bile duct cancer after major hepatectomy was no more than 2% in Japanese high-volume centers, and the 5-year survival rate was about 30 to 40%. Hepatopancreatic duodenectomy, HPD, carries high surgical risks. However, this operation can be performed safely in selected institutions, offering more than 40% of 5-year survival rate. This is a recent European multi-center retrospective study of HPD, including 29 patients with bile duct cancer. The mortality rate was 17% in bile duct cancer, and the 3-year survival rate was 80%. This will be the real-world data in Europe. Secondly, the optimal surgical procedure for gallbladder neck cancer. The surgical procedure for gallbladder cancer consists of 3 parts: hepatectomy, bile duct resection, and nodal dissection. For example, in the treatment for T2 gallbladder cancer, partial hepatectomy without bile duct resection and with sampling or D2 dissection will be selected. In patients with T3 gallbladder cancer involving the hepatic hilum, right hemihepatectomy with extrahepatic bile duct resection and D2 nodal dissection will be required. In patients with T3 gallbladder cancer involving the hepatic hilum and the pancreatic head, right HPD may be necessary. The 5-year survival rate of patients with gallbladder cancer involving the hepatic hilum was 17% in National Cancer Center Hospital in Tokyo. This survival rate was the best among the reports on this type of advanced gallbladder cancer. On the other hand, Right HPD for gallbladder cancer was associated with higher mortality rate than that for bile duct cancer. The 5-year survival rate was 0%, and the median survival time was 8 months. Thus, upfront right HPD for gallbladder cancer cannot be recommended. Any adjuvant chemotherapy will be needed. Finally, I will introduce the recent adjuvant chemotherapy for biliary tract cancer. In BILCAP trial, per protocol analysis showed better overall survival of adjuvant capecitabine group than that in the observation group after curative resection for biliary tract cancer. Thus, adjuvant chemotherapy is weekly recommended. IASGCON trial performed in Japan revealed that overall survival rate of patients with adjuvant S1 treatment for resected biliary tract cancer was superior than that of patients with surgery alone. Thus, adjuvant S1 therapy is becoming the standard treatment for biliary tract cancer after surgical resection. In Japan also, a randomized control trial to reveal the efficacy of neoadjuvant gemcitabine plus cisplatin plus S1 treatment for resectable biliary tract cancer is ongoing. In summary, preoperative diagnosis of tumor extension is important for the treatment of hilar bile duct cancer. However, preoperative precise diagnosis of gallbladder neck cancer is sometimes difficult. Surgical procedure for both cancer requires high HPP strategies and skills. Adjuvant chemotherapy for biliary tract cancer can be recommended. Thank you for your attention. Hello everybody, I am Sakamoto from Kyoto University.
Thank you very much.
Thank you, Dr. Sakamoto, for a beautiful lecture and elaboration. The floor is open for questions.
Hello, good afternoon. I am Dr. T.D. Yadav from PGI Chandigarh. So you did not mention anything about staging laparoscopy, either before portal embolization or after, neither in gallbladder cancer involving neck nor in Hilar Cholangiocarcinoma. So you are not doing it, or you just missed in the talk? I want to know your opinion about staging laparoscopy.
Yes, thank you very much for a nice question. Staging laparoscopy will be, I think, very important to obtain precise diagnosis before, especially before you do the extensive resection. But due to the many reasons, the number of operations or the circumstances, we don't have time to do the laparoscopic staging laparoscopy now. I think it's important. Thank you.
Dr. Sakamoto, I'm Yoshihiro from Germany. Regarding the BILCAP trial and also the PRODIGE 12 trial, which has the similar or almost the same chemotherapy regime, both trials unfortunately included all type of bile duct cancers, including distal bile duct, gallbladder, intrahepatic, and peri-hilar. In your experience, because these data is not available, in the adjuvant setting, which groups benefits most and which is practically has no effect of the adjuvant chemotherapy?
I'm sorry, I can't follow you. I can't follow you. Would you please?
Yeah, in the BILCAP trial.
A BILCAP trial, okay.
Yeah, so they included all type of bile duct cancers. Also distal bile duct, gallbladder, peri-hilar, and intrahepatic cholangiocarcinoma. So from these four, which group does benefit the most? What is your experience?
Yeah, well, I'm sorry, I don't see the detail of the data. But as you know, the biliary cancer has many diversity. Yes, but in my opinion, the adjuvant therapy will be useful for bile duct cancer rather than gallbladder cancer or intrahepatic cholangiocarcinoma. It's my opinion or impression.
Any further questions? I have one question for you, Dr. Sakamoto. How often and why do you use frozen section when you don't have a preoperative diagnosis? Frozen section.
Frozen section. What kind of frozen section analysis?
When you don't have
intraoperative.
Intraoperative, yeah.
Okay, we will do it always, and we will check the status of the ductal margin always using the frozen section analysis. But it's sometimes maybe some true positive or the false negative or something. But the important thing for the bile duct cancer, we must differentiate the membranous invasion from the intestinal invasion. You know, if the cancer invasion is limited only the membrane, it is not associated. Even if it is positive, it is not associated with worse prognosis. So we don't have to do the additional resection. But the ductal margin is positive for the intestine, the wall of the bile duct. It is associated with worse prognosis. So we have to do the additional resection in such cases. So we use the frozen section always. Thank you.
Thank you, Dr. Sakamoto. We will now go on to the next session.
Okay, thank you very much.